Previously on Golden Hour podcast MRCEM Primary Edition, we were deep diving into head and neck anatomy. So let's dive back into head and neck anatomy part 2.
Two images, one stacked on top of the other. They specifically mention it's much worse when they try to read a book or when they are walking down a flight of stairs.
That is the absolute classic presentation of a trochlear nerve palsy, cranial nerve 4.
Why the stairs? Why is that the specific complaint the exam always uses?
It is all about the specific muscle action. The trochlear nerve supplies the superior oblique muscle. The primary action of the superior oblique is to depress the adducted eye, meaning looking down and in towards your own nose. That is exactly where your eyes naturally go when you look at your feet to walk down a set of stairs. If that muscle is paralyzed, the eye drifts upwards and you get that vertical double vision.
Scenario 2. The eye is stuck looking inward, adducted towards the nose, and the patient has horizontal diplopia.
That is the adducens nerve, cranial nerve 6. It supplies the lateral rectus muscle. The name gives it away. Abducens literally means to abduct, to pull the eye out laterally. If it's paralyzed, the medial rectus pulls unopposed and the eye is dragged inward.
And the clinical context here is vital for the primary exam. The abducens nerve has a notoriously long, exposed anatomical path inside the skull.
Right. It runs right through the absolute middle of the cavernous sinus. It's basically swimming in there. So if you have a cavernous sinus thrombosis, which is a lethal clot in that venous pool, the abducens nerve is almost always the first one to fail. It is the canary in the coal mine for cavernous sinus pathology.
Scenario 3. The famous down and out eye. The eyelid is completely droopy, severe apoptosis, and the pupil is blown wide open, dilated.
That is a complete oculomotor nerve palsy, cranial nerve 3.
Let's break down that down and out position for a second. Why does the eye specifically go there?
Think of the eye as a ball being held by puppet strings. The oculomotor nerve controls almost all of those strings, the superior, medial, and inferior recti, and the inferior oblique. When CN3 is dead, all those strings are suddenly cut.
So what's left pulling?
The only muscles left working are the superior oblique, controlled by CN4, which pulls down, and the lateral rectus, controlled by CN6, which pulls out. So the eye is physically dragged down and out by the only two muscles still functioning.
And the dilated pupil, this is what we call the surgical third nerve palsy, right?
Exactly. The pathway here is heavily tested. The parasympathetic fibers that constrict the pupil run on the very outside of the oculomotor nerve bundle. Imagine them like the skin of a sausage.
Okay, visual.
If you have a compressive lesion outside the nerve, like a posterior communicating artery aneurysm expanding, it presses on the outside skin of the nerve first. So the very first sign before the eye even stops moving is a blown pupil. That is a massive neurosurgical emergency.
Let's stick with pupils for a moment. Scenario 4. A Marcus gun pupil. You are doing the swinging flashlight test. You shine the light in the good eye, and both pupils constrict normally. You swing the light over to the bad eye, and they both dilate.
This indicates a defect in the optic nerve, cranial nerve 2. It's an afferent pupillary defect. Basically, the brain isn't seeing the light clearly coming in from that bad eye. Maybe it's optic neuritis from MS or severe glaucoma.
So why do they dilate?
When you swing the light from the good eye to bad eye, the brain essentially thinks you just turned the lights off because the signal is so weak. So it actively dilates the pupils to try and let more light in. It's a paradoxical dilation, and it proves the optic nerve is failing.
Scenario 5. Let's do visual fields. Bitemporal hemianopia. The patient has extreme tunnel vision. They have lost their peripheral vision on both the left and the right sides.
That is direct compression of the optic chiasm.
What's the usual suspect causing the compression here?
Almost always a pituitary adenoma. The optic chiasm sits directly on top of the pituitary fossa. As the benign tumor grows upwards, it presses directly on the crossing fibers right in the middle of the chiasm, which physically knocks out the temporal visual fields.
And if we add a twist for scenario 6, the patient has the tunnel vision, but they also present with hypertension, coarse facial features, and enlarged spade-like hands.
Then you are looking at acromegaly. It's still a pituitary tumor compressing the chiasm, but this specific tumor is actively secreting excess growth hormone.
Moving further back into the brain, visual field defects can be really tricky to visualize under exam conditions. Scenario 7, a right homonymous hemianopia. The patient cannot see the right half of the world with either eye.
The lesion is in the left optic tract. The golden rule here is, once you pass the optic chiasm, everything is completely contralateral. The left brain sees the right world.
Scenario 8, the classic pie-in-the-sky defect. A superior quadrantanopia on the opposite side. Basically, just the upper outer corner of their vision is completely missing.
That is a temporal lobe lesion. It specifically affects Meyer's loop.
I always struggle to remember this one. How do we easily differentiate temporal lobe from parietal lobe field defects for the paper?
Think of the gross anatomy. The temporal lobe is lower down in the skull, right near the ear. The optic fibers that loop through there, Meyer's loop, carry information from the inferior retina.
And the inferior retina sees the superior world.
Exactly, because the lens flips the image. So temporal lesion, which is low, equals a superior defect, which is high, pie in the sky. Conversely, a parietal lobe lesion, which is physically high up, hits the fibers for the lower world, giving an inferior defect, pie on the floor.
Pie in the sky is temporal. Got it. Scenario 9. A homonymous hemianopia, but specifically with macular sparing. The peripheral vision on one side is totally gone, but the very center of their vision, the little pinhole in the middle, is perfectly preserved.
That is a classic posterior cerebral artery, or PCA, stroke. The occipital pole at the back of the brain, where the macula is represented, has a unique dual blood supply. It gets blood from the PCA, but it also gets collateral flow from the middle cerebral artery, the MCA.
So it has a backup generator?
Precisely. So
Yep.
even if the TCA is completely blocked by a clot, the NCA keeps that tiny macular region alive. Macular sparing equals PCA stroke.
Scenario 10. Sudden, completely painless loss of vision in one eye. The patient says it was exactly like a dark curtain falling over their eye. You look in with your ophthalmoscope and see a pale white retina with a bright cherry red spot in the center.
Central retinal artery occlusion, CRAO. The cherry red spot is actually the normal vascular choroid showing through the very thin fovea because the rest of the surrounding retina is swollen, pale, and dying from ischemia.
Scenario 11. A patient gets punched squarely in the eye in a bar fight. Now they have diplopia, specifically on upward gaze. They physically cannot look up.
This is an orbital blowout fracture. The high-yield anatomical structure the exam wants is the inferior rectus muscle.
Why specifically the inferior rectus?
The floor of the orbit is made of incredibly thin bone, a part of the maxilla. When the pressure inside the eye socket spikes from a fist, that thin floor just blows out and shatters into the maxillary sinus below it. The inferior rectus muscle and a bunch of orbital fat literally fall down into the crack and get entrapped.
So it's tethered.
It's mechanically stuck. So when they try to look up, the muscle can't stretch. The eye is tethered to the floor.
Scenario 12. You have a patient with a corneal ulcer from leaving their contact lenses in for a week. It is incredibly, blindingly painful. Which specific nerve is screaming right now?
The cornea is supplied by the ophthalmic division of the trigeminal nerve, V1, specifically the nasociliary branch. It is one of the most densely innervated and sensitive tissues in the entire human body.
Scenario 13. We actually touched on this earlier, but let's formalize it. A patient presents with a high fever, a severe headache, a rigid neck, and horizontal diplopia.
Cavernous sinus thrombosis. And again, always watch for that cranial nerve 6 palsy as the very first sign, because it is running right through the middle of the infected sinus.
Scenario 14. Horner's syndrome. This is an absolute favorite triad on the written paper. Meiosis, which is a small constricted pupil, whitosis, a droopy eyelid, and anhidrosis, a completely dry face on one side.
This triad represents damage anywhere along the cervical sympathetic chain.
Scenario 15. Let's compare two droopy eyelids. A patient has complete ictosis. The eye is shut completely tight like a curtain, and when you lift it, the eye is down and out.
Complete ptosis almost always points to an oculomotor nerve, CN3, palsy. The levator palpebrae superioris muscle is the main heavy lifter of the upper eyelid, and it is supplied entirely by CN3. If that nerve is dead, the curtain falls completely.
Now contrast that with the betosis in Horner's syndrome.
In Horner's syndrome, the ptosis is only partial. It's very subtle. That is because the main levator muscle, the CN3 muscle, is working perfectly fine. The muscle that is knocked out in Horner's is Meller's muscle, which is a tiny, sympathetically innervated smooth muscle that just helps lift the lid the last millimeter or two. So you get a slightly lazy lid, not a closed one.
Scenario 16. Corneal abrasion sensation, just to be highly specific for the exam recall.
It is specifically mediated by the long ciliary nerves, which are direct branches of V1.
Scenario 17. Someone faints dead away during an eye exam when the doctor touches their eye or applies firm pressure to the globe.
This is the oculocardiac reflex. The afferent limb feeling the pressure is V1, and the efferent limb responding is the vagus nerve, which violently slows the heart rate. It is essentially a profound vasovagal response triggered by visceral eye stimulation.
Scenario 18. A 45-year-old patient is reading a restaurant menu and suddenly realizes they have to hold it far away because they can't focus on the small text. Which muscle is failing here?
That is the ciliary muscle inside the eye. It controls accommodation, which is the process of actively changing the shape of the lens to focus on near objects. It weakens with age.
Scenario 19. You have a patient with a nasty eyelid infection, a sty or maybe some localized cellulitis, but you desperately need to know if it has spread deeper into the orbit, which is limb or life-threatening. What is the key anatomical barrier here?
The orbital septum. It's a tough fibrous sheet, the tarsal plate, that acts exactly like a firewall. Infection isolated in front of it is preseptal cellulitis, which you can often treat with oral antibiotics and send home. Infection that breaches behind it is orbital cellulitis. That requires admission, 5E antibiotics, and maybe even emergency surgery to save their vision.
And scenario 20. A patient takes a piece of glass to the eye, causing a deep 2-millimeter laceration at the 12 o'clock position of the upper eyelid.
You have almost certainly severed the levator calcaris superioris tendon. If you just superficially stitch the skin in the ED, they will heal with a permanent severe ptosis. You need to identify and repair the muscle layer itself.
Okay, that was an intense section. Let's do a rapid recall for ophthalmology to cement it.
Go for it. Let's see how they do.
A patient walks down a flight of stairs and sees double. Which specific nerve is out?
Trochlear nerve, CN4. It supplies the superior oblique muscle.
What visual field defect do you get if you have a tumor isolated in the temporal lobe?
Superior quadrantenopia. Remember the rule, temporal equals pie in the sky.
The eye is down and out with a massively blown pupil. What is the immediate diagnosis?
A surgical oculomotor, or CN3, palsy. You must rule out a posterior communicating artery aneurysm immediately before it ruptures.
Which muscle gets physically trapped in an orbital floor blowout fracture?
The inferior rectus muscle.
Now, before we move on, I promised a very simple mnemonic for the superior orbital fissure. There is a lot of critical neurovascular traffic passing through that tiny hole in the back of the eye socket.
It is the absolute main highway for the eye. You have cranial nerve 3, cranial nerve 4, the first branch of the trigeminal V1, and cranial nerve 6, all passing through.
The way I always remember it is just the numbers like a straight flush in poker. 3, 4, 5-1, and 6.
Simple is always best in an exam. 3, 4, 5, 1, 6. They all go straight through the superior orbital fissure.
Moving smoothly on to section 3. CNS and spinal cord, this is where we really get into strokes and traumatic spinal syndromes.
This section is critical because the clinical picture maps absolutely perfectly to the cross-sectional anatomy. If you know where the tracks live, you can pinpoint the injury within millimeters.
Let's start with a really scary one in the rhesus room. Scenario 1. A patient is brought in completely unconscious. They have pinpoint pupils and quadriparesis, meaning profound weakness in all 4 limbs. They are effectively locked in or comatose.
That specific constellation of signs is a pontine hemorrhage, a massive bleed in the pons of the brainstem.
Why the pinpoint pupils, though? Usually in the ED, we think of opiate overdoses for pinpoint pupils.
It's a great question. In a pontine bleed, the expanding hematoma disrupts the descending sympathetic pathways that run right through the brainstem. Without that sympathetic fight-or-flight dilation signal getting through, the parasympathetic system runs completely unchecked and tightly constricts the pupils to tiny pinpoints. It mimics an opiate overdose perfectly, but the quadriparesis tells you it's a catastrophic brainstem bleed.
Now let's go out to the brachial plexus. You see a baby after a very difficult shoulder dystocia delivery, or maybe a motorcyclist who landed hard on the point of their shoulder. Scenario 2. The arm is hanging limply by their side, it's internally rotated, and the wrist is fully flexed backwards. The classic waiter's tip position.
That is Erb's palsy. It is a traction injury to the upper trunk of the brachial plexus, specifically involving nerve roots C5 and C6. You completely lose the shoulder abductors and the external rotators, so the arm is just mechanically stuck, adducted, and internally rotated.
Scenario 3. Let's look at the other end of the plexus, the claw hand. The small intrinsic muscles of the hand are severely wasted, and the fingers are curled up into a tight claw.
That is Klumpke's palsy. It's an injury to the lower trunk, primarily roots C8 and T1. This classically happens when the arm is violently pulled upwards, like someone falling out of a tree and blindly grabbing a branch to catch themselves. The upward yank tears the lower roots.
Now, this next distinction is absolutely vital for the MRCEM. You need to be able to confidently differentiate spinal cord syndromes. Scenario 4. An elderly patient trips on a rug, falls forward, and hits their chin on a table, violently hyperextending their neck. They present with weakness in the upper limbs that is much, much worse than the weakness in their lower limbs. Their legs are actually okay, but their hands are completely useless.
This is central cord syndrome, highly tested.
Why the massive discrepancy between the arms and legs? Why are the hands weak, but the legs are walking?
It is all about the anatomical map of the corticospinal tract inside the spinal cord. Think of the spinal cord like a busy road. The nerve fibers for the upper limbs, the cervical fibers, run centrally, right in the middle of the road. The fibers for the legs run laterally, out on the sidewalks.
Okay, I'm picturing it.
When you violently hyperextend the neck, the ligamentum flavum buckles inward and physically bruises the absolute center of the cord. It hits those arm fibers right in the middle, but the leg fibers safely out on the outside edges are spared.
I always use the phrase, mud on the center of the road. The arms are trapped in the mud in the middle.
Exactly right. Now contrast that with scenario 5. A patient has a severe flexion injury or maybe a vascular event. They have complete loss of motor function below the lesion and complete loss of pain and temperature sensation. But, and this is the key, they have perfectly preserved proprioception. They can feel a tuning fork vibrate on their toes. That is anterior cord syndrome. This is usually vascular in nature, often an occlusion of the anterior spinal artery.
Why is proprioception magically spared while everything else dies?
Because the spinal cord has two distinct blood supplies. The front 2/3 of the cord is fed by the anterior spinal artery. That real estate covers motor, the corticospinal tracts, and pain, the spinothalamic tract.
It's in the back.
The back 1/3 is fed by the paired posterior spinal arteries. The dorsal columns, which exclusively carry proprioception and deep vibration, live entirely in the back. So the front of the cord dies from the stroke, but the back survives perfectly fine.
So extending that logic to scenario 6, an isolated loss of proprioception. The patient is stomping their feet heavily when they walk because they literally don't know where the ground is.
That would be a posterior cord syndrome, isolating and destroying just the dorsal columns. We historically see this in severe B12 deficiency or tertiary syphilis, tabes dorsalis.
Let's move up to the brain lobes and stroke localization. Scenario 7, expressive aphasia. The patient understands everything you say to them, they follow commands, but they physically cannot get the words out. They're incredibly frustrated and their speech is very telegraphic.
That's a lesion in Broca's area. It is anatomically located in the frontal lobe, specifically the inferior frontal gyrus. The easy way to remember it is Broca is broken speech.
Scenario 8, receptive aphasia. The patient talks fluently, smoothly, but it is total, absolute nonsense, complete word salad. And more importantly, they don't understand a word you are saying to them.
That is Wernicke's area, located in the temporal lobe, specifically the superior temporal gyrus. The memory hook here is Wernicke's is wordy but completely wrong.
Scenario 9. A patient complains of severe vertigo, ataxia, and they have the classic crossed signs. They have numbness on one side of their face and numbness on the completely opposite side of their body.
This is Wallenberg syndrome, also known as lateral medullary syndrome. The specific artery involved here is the PICA, the posterior inferior cerebellar artery.
Why do we get those cross signs? That always confuses people.
It's about where the wires cross. The spinal tract of the trigeminal nerve, which handles face sensation, is ipsilateral in the medulla. It hasn't crossed yet. But the spinothalamic tract, which handles body pain, has already crossed over, way down in the spinal cord.
So a single bullet hits both.
Exactly. A single ischemic lesion in the lateral brainstem catches the face fibers before they cross, and the body fibers after they've crossed, hence crossed signs.
Scenario 10. Let's look at tremors. An intention tremor. The patient's hands are perfectly fine at rest, but the moment they reach out to grab a cup of coffee, they start shaking violently right at the end of the movement.
That specifically points to a cerebellar injury or lesion. The cerebellum smooths out purposeful movement.
Contrast that with scenario 11, a resting pill-rolling tremor. They're shaking constantly while just sitting still in the chair, but the moment they reach for the cup, the shaking actually stops. Plus, they have severe muscle rigidity.
That pathology is deep in the basal ganglia, specifically the substantia nigra. This is the classic presentation of Parkinson's disease.
Scenario 12, a patient arrives screaming about the worst headache of my life, a classic thunderclap subarachnoid hemorrhage. Where is the ruptured aneurysm usually anatomically located?
The anterior communicating artery in the circle of Willis. It is by far the most common site for a baryaneurysm to form and ultimately rupture.
Scenario 13. What if that same patient has a cranial nerve 3 palsy? They have a down-and-out eye along with that worst headache.
Then you need to immediately look at the posterior communicating artery, the PCOM. It runs anatomically right next to cranial nerve 3. A rapidly expanding aneurysm there will acutely compress the nerve before it even bursts.
Scenario 14. A patient has a stroke causing severe face and arm weakness, much more profound than their leg weakness. And if it's on the left side of the brain, they also have aphasia.
That is the hallmark of a middle cerebral artery, or MCA, stroke. The MCA supplies the entire lateral surface of the brain cortex, which is exactly where the face and the arm are mapped out on the motor homunculus.
And if it was reversed, if the leg was completely paralyzed but the arm was relatively okay?
That would be an anterior cerebral artery, an ACA stroke, because the ACA wraps around to supply the medial inside surface of the hemispheres where the leg is mapped.
Scenario 15. A patient survives a subarachnoid bleed, but a week later they develop severe hydrocephalus. Why does the fluid suddenly build up?
The stagnant blood from the hemorrhage actually clogs up the arachnoid granulations. These are the tiny one-way drains that allow cerebrospinal fluid to reabsorb back into the venous system. If they are plugged with old, sticky red blood cells, the fluid just backs up inside the skull. This is a communicating hydrocephalus.
Scenario 16. You look at a head CT and see a hemorrhage that is strictly restricted to just the lateral ventricles. It hasn't spread.
The anatomical blockage keeping it contained there is at the foramen of Monroe, also known as the interventricular foramen.
Let's quickly drop down to the gut for scenario 17. A newborn baby with a massive megacolon and delayed passage of meconium. Hirschsprung's disease. What specific anatomical structure is missing?
The congenital defect is the complete absence of the myenteric plexus, or Auerbach's plexus, in the wall of the distal gut. No nerve plexus means that segment of bowel physically cannot relax or push. It just stays tightly constricted, acting as a functional bowel obstruction.
Scenario 18. A young patient with multiple sclerosis presenting with acute blurry vision from optic neuritis. What is the fundamental physiological failure occurring in the nerves?
It is severely impaired saltatory conduction due to demyelination. The myelin sheath insulation is literally being eaten away by autoantibodies, so the electrical signal leaks out and slows down or fails completely.
Scenario 19. You are about to perform a lumbar puncture in the ED. Where exactly do you stick the needle?
The safe zone is L3, L4, or anywhere below that.
Why there specifically?
Because the solid spinal cord itself, the conus medullaris, ends much higher up at the L1 or L2 vertebral level in adults. Below that level, it's just the cauda equina, which is a bunch of loose nerve roots floating in a big pool of fluid.
Like spaghetti and water.
Exactly like spaghetti and water. You can safely push those floating roots aside with a blunt spinal needle, but you absolutely do not want to spear the solid, untethered spinal cord higher up.
Scenario 20. You are pushing the spinal needle in, and you feel a distinct give, followed by a second pop. What anatomical layers did you just puncture?
The first dense resistance you push through is the ligamentum flavum. The second distinct pop is the dura mater. The moment you pop through the dura, you are officially in the subarachnoid space and should get CSF fluid back.
Excellent. Rapid recall time for the CNS section.
Let's go.
Artery most commonly involved in the worst headache of life.
Anterior communicating artery.
Which spinal cord syndrome presents with perfectly spared proprioception?
Anterior cord syndrome. Remember the rule? The front of the cord dies, but the back survives.
The waiter's tip palsy. Which specific nerve roots are torn?
C5 and C6. That's Erb's palsy.
A patient has a severe tremor, but only when actively reaching for an object. Where is the anatomical lesion?
The cerebellum.
You are absolutely crushing this. Let's move to section 4, skull, foramina, and blood supply. This covers major head trauma and some really key orthopedic fractures that they love to test.
This is the real nuts and bolts of trauma anatomy. The examiners love this entire section because it relates directly to your ability to interpret an emergency CT scan.
Let's start with a classic. Scenario 1, an extradural hematoma. A young cricketer gets hit violently on the side of the temple by a fastball. They are knocked out briefly, then they wake up and feel totally fine. That's the famous lucid interval. But an hour later, they suddenly collapse, blow a pupil, and die. What exactly is bleeding inside their skull?
The middle meningeal artery. It's an arterial bleed under high pressure.
Why is a hit to the temple so uniquely dangerous?
That specific anatomical area on the side of the skull is called the pterion. It is a junction point where 4 different skull bones meet, and the bone there is incredibly thin. The middle meningeal artery runs in a deep groove right underneath that thin sheet of bone. A direct hit easily snaps the bone, and the sharp fracture lines tear the high-pressure artery wide open.
And what specific hole in the base of the skull does that artery come through to get inside in the first place?
The foramen spinosum. Very commonly tested fact.
Scenario 2. You have a patient with a basal skull fracture. They are complaining of complete numbness of their upper teeth and their upper lip, which is V2 territory. Which specific foramen is involved in the fracture line?
The maxillary nerve, V2, exits through the foramen rotundum.
Scenario 3. What if the fracture line is running through the foramen ovale?
That puts the mandibular nerve, V3, at high risk of being sheared.
Scenario 4. A fracture line running straight through the stylomastoid foramen.
That is the main exit point for the facial nerve, cranial nerve 7. You should expect a complete peripheral facial paralysis on that side.
Scenario 5. The so-called danger area of the face. A patient pops a nasty pimple on their nose or upper lip, and a few days later presents to the ED with a raging headache, fevers, and confusion. How did a simple skin infection get all the way into the brain?
The localized infection entered the facial vein. The facial vein communicates directly with the cavernous sinus deep inside the skull via the ophthalmic veins. Crucially, and this is the exam point, these veins are completely valveless.
Meaning flow can go both ways.
Exactly. This means blood, and therefore virulent bacteria, can flow freely backwards from the surface of the face directly into the intracranial venous sinuses, causing a massive lethal thrombosis.
Scenario 6. A traumatic fracture involving the internal acoustic meatus. What deficits do you expect?
You will see a combined loss of hearing and balance, which is cranial nerve 8, and a loss of facial movement, cranial nerve 7, because both of those critical nerves travel tightly bundled together inside that narrow bony canal.
Scenario 7. Severe blunt trauma to the center of the skull base, specifically fracturing the sella turcica.
The sella turcica is part of the sphenoid bone, and it acts as the bony cup housing the pituitary gland. So you'd worry about panhypopituitarism or a massive CSF leak.
Scenario 8. We touched on this, but let's formalize it. Which specific bone primarily forms the fragile floor of the orbit that shatters in a blowout fracture?
Maxillobone.
Scenario 9. Again, repetition is key for retention. A penetrating injury to the superior orbital fissure. What is damage?
Cranial nerve 3, 4, the ophthalmic branch of 5, which is V1, and cranial nerve 6. Remember the straight flush, 3, 4, 5, 1, 6.
Scenario 10. A patient comes in with a relatively small scalp laceration, but it is bleeding absolutely profusely and the wound edges just will not stay closed. Why do scalp wounds behave like this?
The bleeding itself is usually coming from the highly vascular, loose areolar tissue layer. But the reason the wound gapes open so stubbornly is the epicranial aponeurosis, also known as the galea.
How does that work?
The blood vessels in the scalp are tightly tethered to this dense fibrous sheet. So when the vessels are cleanly cut, they physically cannot retract and spasm to clot off like normal vessels do. The aponeurosis holds them permanently open, acting like a garden hose.
Let's move down to the arm. Orthopedic anatomy is huge on the written paper. Scenario 11. A patient falls and presents with the classic dinner fork deformity of the wrist.
That is a Colles fracture of the distal radius. The distal bone fragment is displaced dorsally, pointing upwards, which visually mimics the curve of a dinner fork.
Scenario 12. A young patient falls hard on an outstretched hand. The initial ED x-rays look perfectly normal, no obvious breaks, but they have intense localized tenderness right in the anatomical snuff box at the base of the thumb.
You must treat that as a scaphoid fracture, put them in a splint, and arrange follow-up imaging until proven otherwise.
Why is the scaphoid so incredibly high yield for examiners?
Because of its unique and precarious blood supply. The arterial blood flows retrograde, meaning it enters the distal end of the bone and flows backwards to feed the proximal end. A fracture right through the waist of the scaphoid completely severs the blood supply to the proximal pole, predictably leading to a vascular necrosis and chronic non-union of the bone.
Scenario 13. A patient has a massive carpal bone dislocation and presents with acute carpal tunnel symptoms, meaning a completely numb median nerve distribution.
That is the lunate bone. It is the one carpal bone that loves to pop out anteriorly directly into the tight space of the carpal tunnel, instantly crushing the median nerve against the flexor retinaculum.
Scenario 14. A deep laceration, bleeding heavily, exactly 5 centimeters above the medial epicondyle of the elbow. What vessel is cut?
The ulnar collateral artery.
Now let's do the humerus fracture progression. The exam absolutely loves to break the humerus at 3 different specific levels to test if you know which nerve is sitting right next to the bone. Scenario 15. A mid-shaft humerus fracture, and the patient presents with a profound wrist drop.
That is a radial nerve injury. The radial nerve sits tightly against the bare bone as it wraps around the back of the arm in the spiral groove. If the shaft snaps right there, the nerve is either stretched, bruised, or completely severed by the jagged bone ends. Wrist drop equals radial nerve.
Scenario 16. A fracture much higher up, right at the surgical neck of the humerus.
That puts the axillary nerve in the crosshairs. Injury here causes a distinct loss of sensation over the regimental badge area on the lateral shoulder and profound weakness in shoulder abduction because it knocks out the deltoid muscle.
Scenario 17. A fracture way down at the bottom. A supracondylar fracture, which is incredibly common in children falling off monkey bars.
The critical structures at risk here are the anterior interosseous nerve, which is a branch of the median nerve, and the brachial artery.
This is a limb-threatening injury, isn't it?
Yes, this is the exact fracture that causes the dreaded Voltman's ischemic contracture if the brachial artery is kinked over the bone fragment and the ischemia is missed by the ED doctor.
Scenario 18. A direct blow or avulsion fracture, specifically of the medial epicondyle, right where your funny bone is.
That targets the ulnar nerve. You should expect to see ulnar nerve palsy signs, specifically clawing of the 4th and 5th fingers.
Scenario 19. The winged scapula. A patient is asked to push hard against a wall with both hands, and their shoulder blade pops out prominently on their back like an angel's wing.
That indicates an injury to the long thoracic nerve. It supplies the serratus anterior muscle, which normally holds the scapula flat against the ribs. The mnemonic is C567, raise your wings to heaven.
Scenario 20. A patient suffers penetrating neck trauma and subsequently cannot shrug their shoulders at all.
We discussed the muscle earlier. That is a direct laceration of the accessory nerve, cranial nerve 11, in the posterior triangle of the neck.
All right, rapid recall for section 4. Let's see if the orthopedic knowledge stuck.
Hit me with them.
Which specific nerve sits in the spiral groove of the humerus and causes a wrist drop when injured?
The radial nerve.
Which major artery runs straight through the foramen spinosum?
The middle meningeal artery, the one that causes extradural bleeds.
Which carpal bone is maximally tender in the anatomical snuff box?
The scaphoid bone. Beware the avascular necrosis.
A child comes in with a nasty supracondylar humerus fracture. Which specific artery are you desperately worried about being kinked?
The brachial artery.
You are absolutely crushing this. We are on the final stretch. Section 5, thorax, neck, and diaphragm.
Let's bring it all home.
Scenario 1, thoracic outlet syndrome. A patient complains of severe arm pain, tingling, and numbness, specifically when they lift their arms up over their head to paint a ceiling or hang laundry.
This is caused by mechanical compression of the subclavian artery and the lower trunk of the brachial plexus as they exit the tight space of the neck and pass over the first rib. Lifting the arms narrows that space even further, pinching the structures.
Scenario 2, the ultimate rhesus room nightmare. An emergency surgical airway, the cricothyroidotomy. You have a patient, you can't intubate them, you can't ventilate them with a bag, they are dying. You need to cut the front of the neck right now. Where exactly do you cut?
You must cut through the cricothyroid membrane. It is safely located in the palpable notch between the prominent thyroid cartilage, which is the Adam's apple, and the thick cricoid cartilage ring right below it.
What happens if you miss and go lower?
You absolutely do not want to cut into the main trachea rings below the cricoid in an emergency. It is highly vascular down there with the thyroid isthmus, and you will cause massive bleeding into the airway. Stay high in the membrane.
Scenario 3, cardiovascular dysphagia. A patient with a long history of severe mitral valve stenosis, which is a heart problem, comes to the ED complaining that they suddenly have trouble swallowing solid food.
This is a brilliant example of anatomical crowding. The left atrium forms the absolute posterior back wall of the heart. The muscular esophagus runs directly behind the left atrium, sandwiched right in front of the rigid spine.
So it gets crushed.
Exactly. If the left atrium becomes massively dilated, which happens when blood backs up from a stenotic mitral valve, it balloons backwards and physically squashes the esophagus against the spine, causing a mechanical swallowing block.
Scenario 4, a young child swallows a coin. This is a classic everyday X-ray question on the paper. Where exactly does that coin get physically stuck?
Foreign bodies reliably get stuck at the 4 main physiological constrictions of the human esophagus. You absolutely need to memorize these 4 anatomical levels.
Let's hear them.
Number 1 is C6. That is the very start of the esophagus at the cricopharyngeal sphincter. Number 2 is down at T4. That is where the rigid aortic arch physically pushes against the esophageal wall. Number 3 is T5, where the left main bronchus crosses over and indents it. And finally, number 4 is T10, which is the tight muscular hiatus where it passes through the diaphragm to join the stomach.
Okay, so C6, T4, T5, and T10. And specifically for the exam, they love to ask why it gets stuck precisely at the T4 level.
And the correct answer is the physical indentation from the aortic arch.
Scenario 5. You need to perform a life-saving chest tube insertion for a massive tension pneumothorax. Where exactly does that large plastic tube go?
You aim for the safe triangle on the lateral chest wall. Specifically, you want the 5th intercostal space exactly in the mid-axillary line. And the most critical technical point, you must always insert the needle and the tube grazing the top border of the rib below the space.
Why always aim above the rib? Why not go right through the middle of the space?
Because the entire neurovascular bundle, the intercostal vein, artery, and nerve, runs hidden in a deep bony groove on the underside, the inferior border, of every single rib. If you accidentally scrape the bottom of a rib with your scalpel, you will slice that high-pressure artery and fill the chest with blood. Always go over the top of the rib.
Scenario 6. A patient is stabbed deeply in the lower chest. A week later, their follow-up x-ray shows the stomach gas bubble is sitting way too high, and the entire hemidiaphragm on the left side is elevated high up into the chest cavity.
That is a clear phrenic nerve injury. The diaphragm on that side is completely paralyzed. Without the constant nerve signal maintaining its firm resting tone, the massive pressure from the abdominal organs just physically pushes the flaccid muscle up into the empty chest space.
Scenario 7. A patient presents with classic pericarditis, retrosternal chest pain that gets better when they lean forward. But they also complain that the pain feels like it's shooting right up into the ridge of their shoulder. Why does heart pain go to the shoulder?
That is classic referred pain via the phrenic nerve again. The phrenic nerve, which originates from nerve roots C3, C4, and C5, provides the main sensory innervation to the fibrous pericardial sac surrounding the heart.
Okay, but how does the shoulder get involved?
The skin over the ridge of the shoulder is also innervated by dermatomes C3 and C4. When the pericardium is inflamed and screaming in pain, those signals travel up the phrenic nerve to the spinal cord. The brain gets completely confused about where the signal originated and frequently misinterprets the heart pain as coming from the shoulder skin.
Scenario 8. You are performing an emergency pericardiocentesis, draining a massive rim of fluid from around a dying heart. You accidentally push the long needle just a centimeter too far. Which actual chamber of the heart are you guaranteed to spear?
You will hit the right ventricle. Anatomically, it is by far the most anterior chamber of the heart, sitting directly behind the sternum and the xiphoid process where your needle is aiming.
Let's talk explicitly about the diaphragm openings. This is pure, unadulterated rote learning for the primary paper. Scenario 9. A patient has a massive venous thrombosis exactly at vertebral level T8. What major vessel runs through the diaphragm right there?
T8 is the opening exclusively for the inferior vena cava, the IVC.
Scenario 10. A patient has a severe sliding hiatal hernia causing terrible reflux. Which specific anatomical level has widened to let the stomach slide up?
That is at T10. This is the esophageal hiatus.
Scenario 11. A penetrating trauma straight through the back, crushing the structures at the T12 opening of the diaphragm. What is destroyed?
The T12 opening is the aortic hiatus. It is packed. It contains the descending aorta, the main thoracic duct carrying lymph, and the azygos vein.
We absolutely need a solid mnemonic for these 3 vital levels.
The classic medical school mnemonic is I ate 10 eggs at 12.
Let's break that down.
I8 stands for IVC at 8. 10 eggs stands for the esophagus at 10. And at 12 stands for the aorta at 12.
Or, if you prefer acronyms, you can use Voice of America, VOA. Vena cava is 8, esophagus is 10, aorta is 12. Use whatever sticks in your brain.
Exactly. Just don't mix up the numbers on exam day.
Scenario 12. Surface anatomy for listening to the heart. You want to perfectly auscultate a suspected aortic valve murmur. Where exactly do you put your stethoscope on the chest wall?
You place it in the second right intercostal space right next to the sternal edge.
Scenario 13. What about listening for a mitral valve issue, like that stenosis we talked about earlier?
You move all the way down to the 5th left intercostal space, perfectly aligned with the midclavicular line. This is exactly where you palpate the apex beat of the heart.
Now let's rattle through some key dermatomes. These are absolute free, easy points on the written paper if you know them. Scenario 14. The patient has a band of complete numbness wrapping right around the level of the nipples.
That is dermatome T4. The memory hook is T4 at the teat pore.
Scenario 15. Numbness localized right at the umbilicus, the belly button.
That is T10. The hook is T10 at the belly button.
Scenario 16. Numbness mapping across the level of the siphosternum right at the bottom tip of the sternum.
That dermatome is T6.
Scenario 17. We see a patient who develops a winged scapula, but this time it's specifically after they had a major thoracotomy, lung surgery, not after a blunt trauma.
We mentioned the long thoracic nerve earlier for this exact sign, but in the specific context of chest surgery or placing a lateral chest drain, it is incredibly easily damaged by a surgeon's scalpel because it runs remarkably superficially, straight down the lateral chest wall, right over the ribs.
Scenario 18. A patient is asked to forcefully blow out a set of birthday candles or perform spirometry. Which specific muscles are they actively recruiting to push that air out?
They're primarily using the rectus abdominis muscles and the internal intercostals. Remember the physiology rule. Normal quiet expiration is entirely passive. You just relax your diaphragm and elastic recoil does the rest. But forceful expiration requires heavy active muscle contraction to push the diaphragm back up.
Scenario 19. A patient develops a classic Horner syndrome, the droopy eye and small pupil, immediately after sustaining severe penetrating trauma to the side of the neck.
The cervical sympathetic chain, which controls those facial sympathetic functions, runs tightly packed inside the carotid sheath, deep in the neck. A knife or bullet there easily severs the chain, disrupting the sympathetic supply all the way up to the face.
And finally, we made it to point number 100, scenario 20. You are performing a carotid sinus massage in the resus room. You are desperately trying to stimulate the vagus nerve to break an SVT, a dangerously fast heart rate. Where exactly on the neck do you press your fingers?
You need to apply firm pressure at the level of the superior border of the thyroid cartilage, sitting just medial to the anterior edge of the sternocleidomastoid muscle. That exact landmark is where the carotid artery cleanly bifurcates, and is exactly where the pressure-sensitive carotid sinus sits.
Amazing. Final rapid recall.
Let's finish this strong.
Dermatome for the line of the nipples. Which specific heart chamber is accidentally hit if you push too deep in a pericardiocentesis?
The right ventricle, because it sits right in front.
What is the vertebral level of the diaphragm opening for the esophagus?
T10. Remember the eggs, 10 eggs?
What specific nerve is damaged to cause a winged scapula?
The long thoracic nerve.
He did it. 100 incredibly high-yield clinical anatomy points.
That was an absolute marathon, but here is the real final takeaway. The so what of this entire deep dive.
Yeah, bring it together for us.
We have covered 100 points today, but passing the MRCEM is not just about rote labeling a 2D diagram in a textbook.
Yeah.
It is entirely about predicting the hidden anatomical injury based solely on the clinical deficit walking through the ED doors.
Right.
When you see a patient with a down and out eye, you shouldn't just think, oh, textbook cranial nerve 3 palsy. You should immediately visualize a massive ballooning aneurysm on the posterior communicating artery, physically crushing that nerve against the skull.
It's essentially developing X-ray vision.
Exactly. It's seeing the anatomy working or failing beneath the skin. And here is a slightly provocative thought to leave you with as you head back to your books. Consider how often clinical anomalies or weird presentations are actually just variations of these hard anatomical rules.
What do you mean by that?
If the clinical presentation doesn't fit the neat textbook picture, consider the why. Could it be referred pain, like that bizarre ear pain and mumps we talked about, actively leading you down the wrong diagnostic path? Is the patient complaining bitterly of an earache, but the actual lethal pathology is an abscess in their second lower molar?
That's a great point. Always question the true origin source of the pain. The human body is wired in some incredibly strange, convoluted ways, but the map is always there if you just know how to read it properly.
Precisely. Try to actively visualize these hidden structures on your very next clinical shift. When you are pushing a large chest tube in, actively see the intercostal bundle hiding under that rib. When you shine the light into a pupil, visualize the optic nerve firing and the third nerve responding.
Make it real. That is how you pass this paper. Well, that is it for this extremely dense deep dive. Good luck with the rest of your revision. You have absolutely got this.
Good luck out there.